Okay, yeah, then hi everyone. Thanks for having us here. I hope you all had a great lunch. So how many CKMs are too many? Like 10, 20, just one? I think the question is quite provocative, and of course you cannot just answer it with like a single number. Instead, you have to dive a little bit deeper into this topic. Just for everyone who's new to openEHR, I think all of you have seen it already. It's a screenshot of the global CKM, which is available under ckm.openehr.org. And I think it's one of the really core components of openEHR because it's a tool to collaborate and to develop and to manage your archetypes and templates and so on. But before we dive deeper into this topic, let's first give you a quick introduction about us, what we do, who we are, and why we are here. Hey, Marieke, you want to go first?
So, hi, I'm Marieke. I got hired once upon a time as a data scientist because I have quite some experience working with real-world evidence studies and resource allocation, etc. So I like to write fancy models based on healthcare data. However, as probably most of you know, like garbage in, garbage out, the models are only as good as the data. That's why I kind of drifted away from the modeling itself and went more and more into the topic of how do you actually set up a system such that eventually my successors can do the fancy modeling that I once envisioned. Exactly, and that's exactly what now we are working on.
Okay, yeah. From my side, I'm Henrik Thiess. I work as a solution architect. That means it's my job there to design and to deliver technical solutions. For me personally, you cannot really distinguish between design and delivery because on paper your designed architecture always looks so perfect, but the moment you start to deliver it, the moment it hits the real world, you run into issues, and that's actually where I have the most fun at my work, to try to solve those little issues on the way until a successful implementation, of course. Yeah, so Marieke and I both work for EY's EMEA-based Digital Health Excellence Center. What does EMEA-based mean? It basically means that our team is scattered all across Europe, and so we do not often see each other in person, only in our annual meeting or on conferences like this one. What do we do? Here on the right you see our 4 areas of work, which are architecture and cloud, software development, data management and testing, with our 3 pillars: app development and deployment, healthcare data platforms and electronic medical records, and AI and data for healthcare. So in the end, it's all about technical solution delivery. And for this, our team brings many technical and industry experts who all already have prior experience to healthcare before joining consulting. So we are not your typical consultants, and I can also management consultants mainly, and I can also confirm this for myself. So before joining EY, I worked as a software developer, and I'm asked quite often by former colleagues and friends what I'm doing at EY, at like a big business firm. And maybe at first it doesn't make much sense, but for me, being part of like a very small but focused team within EY, and then go to the client and bring everything else EY has to offer to the client, sounds great, and that's one of the reasons why I'm here with you today. So how do we work? We usually bring our technical expertise into projects. We do not work alone on projects. Instead, we support other local EY teams which are closer to the client, which have the local expertise. And then we support with our technical background. As you can see on the top right, I added many interoperability standards there. Even HS7 version 2 is still unavoidable, even for us at least for now. And all of them already affected our DHEC service model. But as we are on an openEHR conference, let's set the focus only to openEHR. So for openEHR, under think tank and market, this is about EY people observing the market, looking for trends and contributing to think tanks. Here we contribute to an openEHR working group about the federated use of openEHR and how this can be standardized. This group is moderated by a colleague of mine, Eric van Mooyen. Some of you probably know him, and also maybe some of you contribute to this group as well. Already saw some familiar faces in the audience. About business development, we propose to clients solutions including openEHR, but only of course if we think that openEHR is the right tool for the individual need. I think that's very important to mention here. About solution building and ecosystem, we developed our own EY solution called EY Connected Health Cloud, which shows how openEHR repositories from different vendors can be connected together to really highlight vendor neutrality, to really show that with openEHR you do not run into this vendor lock-in situation which occur with more traditional EHR and EMR vendors. And here we use EHR repositories from Beta and from Vita Group. But yet our core competency is in the end-to-end delivery of IT solutions. Here I will not talk much about because we will have another talk about it tomorrow at 12. We'll meet together with my colleague Alistair Allen. We'll talk about how we implemented better openEHR-based clinical data repositories for one of our clients in Germany, a large university hospital. But yeah, as I said before, we are quite scattered across Europe, and here, depending on the region, we already encounter different clinical knowledge managers. For example, in Germany, the HiMate clinical knowledge manager, and of course, in other regions, other CKMs. And this, in the end, brought us to our question, how many CKMs are too many? And with that, I will hand it over to you, Marieke.
Thanks. So coming from to the topic of interoperability from a bit of a sidetrack, I need this cheat sheet today. and also we were really wondering, okay, why is there even more than one CKM? If you really look at it from a very outside perspective, this is one of the things we ask ourselves relatively quickly. Especially due to this paradox in interoperability, right? The more we talk about interoperability, the less interoperable it actually gets. And also now, as Henrik already mentioned, we are working as an EMEA-based team, so we also come across these different CKMs, right? So that made us wonder about like the topic of today, how many CKMs is too many? And we tried to approach that somewhat systematically in our world. So we started with the hypothesis, then some desk research, some interviews. I don't know whether any of you have been interviewed by us, but thank you very much. And then at the end we had an internal discussion, and now we try to summarize what we have found so far to you. I don't promise you that we will give an answer to the question, also because I'm still very schizophrenic about the answer. But we do hope that we spark quite a bit of discussion, and that maybe as a community can converse to one answer. So to start with a high-level overview, by far the largest CKM is the global one with 3,500 users and over 1,400 reviewers. Then there is quite some active local ones, and then there is quite some upcoming CKMs. So for the local ones, they very often tend to have quite a large amount of different archetypes and especially templates that are going around, which of course kind of makes sense. Because especially the templates, that's where you want to have, and the archetypes is where you want to have like the local adjustment implemented, and where kind of like the nitty-gritty details happen. So then we try to look at it from two sides as true consultants, right? Why? Because sometimes we try to pretend to be some. So when does it actually make sense to have a local CKM? And so firstly, one can want to create local archetypes and templates that are relevant for a specific country. We also heard that in the plenary earlier, that sometimes there's really just some local needs and you want to implement it relatively fast. Modeling archetypes can be relatively complex, and it takes quite some time to actually get that through like the official review process at the global CKM level, right? So it gives a certain level of independence and increases speed and sometimes decreases costs a bit. Also competitive reviewing, so by having a local CKM, you can go through the reviewing with increased speed. and thereby you can get some form of like temporary control of the consistency and the integrity of the archetypes and templates that you want to implement locally. So then there is exactly so. As already mentioned, the local CKMs provide some form of version control and also some form of freedom when it comes to the degree of flexibility that you have. And it can be advantageous to create rudimentary archetypes very fast for a specific region, especially when in the region there is a limited amount of licensing. So then you want to kind of escape the rigidity that a global CKM might bring to it. That's at least like the arguments we came across. Also, it can give some more flexibility when it comes to multi-domain applications, and then if you have your governance at a local level very well organized, you can control that relatively well. So that were the arguments that were mentioned quite a bit in favor of creating a local CKM. What is kind of important is that the local CKMs very often start off and stay to be a clone of the global CKM. And that also kind of brings us to like the opposite part of why it does not make sense, or why it might not make sense to create a local CKM. And I think one of the arguments which actually contradicts a little bit what we said before is that it is relatively expensive to maintain it. When you want to have a proper governance model of it, you need to create this entire reviewing process, you need to create all the tools around it, etc. And that just needs to be done rigorously and consistently in order to be sustainable. And that's harder to maintain the smaller or the more fragmented the CKM landscape gets. Then, I mean, it should be kind of open door, but a CKM should not be created just for templates. And as I just mentioned, so that we don't really have the data for that, but some of the CKMs that are there, they have a relatively high number of templates, rather than like that they really change in archetypes. And that makes one wonder, does one really need, so one should be careful not to create a local CKM just because you want to have changes that can actually be solved at a template level. Exactly, so that's also linked to the fact that it's not necessary for developers. I mean, there you can just use Git, right? So it's not really necessary to create a completely local CKM based on only that. And last but not least, the CKMs are actually there to be there for long-term implementation, including its governance, including the control, and including what openEHR was once upon a time based on. So the smaller the scale, the less sense it would make to create a local CKM. Good. So that brings us to like everyone's favorite question. So what? Why should I care? And so why does it matter to have too many CKMs? So one of them we already touched upon. So there is the sustainability of the multiple CKMs, especially when you have a local CKM that is relatively small scale. At the end, the goal, in theory, should be to feed back the new findings into the global CKM. And if that does not happen, is that really sustainable? And do we really go forward as a community and grow from the local learnings that we have made, which would be a good argument to create a local CKM, right? As brought up at first. There is a risk for redundancy of archetypes and templates. So if everyone works in their own silos, then there is the risk that actually the need for a certain archetype was very well founded, but it never got back into the local CKM, into the global CKM, and then someone that might have that same need elsewhere does not find it out, right? That would call for kind of a collaboration system between the different CKMs, which is like only existing on a goodwill basis at the moment, or like there is no governance around that. So yeah, that could be one of the solutions, but it does not necessarily mean it's also a risk, right? Because with collaboration and with systems that facilitate collaborations, you need additional governance, and the question is whether we really would like to go there. So that also brings us a little bit, if we pull that very much into the extreme, right? At a certain moment, one can ask the question: if it gets too fragmented, like what is the difference between like openEHR CKMs and FHIR implementation guides? And so technically, FHIR is a communication standard, and openEHR is a persistent layer. But if you really put us into the extreme, one can wonder what is the added benefit of openEHR, right? Not saying that we are there, just saying that that might be something that is worth considering if you are behind your laptop and think, today I open a new CKM, then think about that. It also is somewhat is like what we started this with, right? You might seek yet another standard. So the more interoperability or the more specification you try to reach, the whole idea of openEHR is actually to govern them on a global level and learn from each other in that way. So that kind of all goes into the direction of maybe temporary local CKMs make sense, as long as eventually they feed back into the global CKM. Which would then, of course, say the ultimate goal would be to create only one CKM, right? That at least, however, that's also where the schizophrenic part kind of comes in. Like maybe, not now, but 5 or 10 years down the drain, interoperability is also to a certain extent there to make sure that we get structured data that we could do analytics on, and to make sure that the data is complete. Now, one might wonder whether AI and generative AI actually can make that a problem of the past. Not there yet, but I think it's worth considering at least. So that's where we kind of want to continue this discussion with you all actually. Eventually, we think that there must always be space for local adaptations, because once they get feedback back into the global CKM, that actually increases our knowledge and makes the global CKM stronger. However, the vision to still have one CKM at the end actually is achievable and should also be the goal. So yeah, that's kind of where we ended our discussion on, and with that, feel free to bring us to new ideas again.
Well, thanks very much, Henrik and Marieke. So we've laid out the exam question there. Seven, you want to go first?
Yeah, sorry, I was joining late, but I think we need to split between archetypes and templates. I don't see templates being on a global CKM if it's not the European Exchange Format or IPS. I just don't. So we're doing modeling for, I don't know, 7 years now, and it's just like, you have really national things, you shouldn't move in the global one. Even think about the concept of encounter. My God, we've been discussing this for 7 years. It's just different depending on the country. So that's things I just don't see in a global CKM. Maybe we should cut probably doing archetypes on local CKMs. We could discuss about that. But the templates, I don't see them anywhere near a global CKM. It's just too local thing. Yeah. In general, yeah. I think probably one thing should be really saying don't do archetypes on a local CKM if it's not really, really, really necessary.
But isn't that also the whole, so again, I'm a relative noob, right, especially in this audience, but so isn't that also the whole idea of the differentiation between archetypes and templates, that templates are relatively easy to adjust, quick to adjust, and also can meet the local needs, so that that would indeed then call for exactly that, right?
What do you mean? The global one?
So to have that adopted on a local level, but then not necessarily change the CKM as a whole.
But then you need to maintain, so the point with the CKM is it's a quality of life feature. Otherwise you need to maintain it on GitHub, because people doing that, it's a pain in the ass. So the CKM just provides it with all the tooling. The guys modeling in Hanover, I don't know what they're doing. So I go into CKM and see, look, the Hanover guys, they have templates, they did some stuff. So it's a lot more about just models, it's about communication, seeing what other people are doing, sharing models, being able to download them. It's a lot, people always discuss about the modeling, but what about the tremendous amount of quality of life features? This is probably what I think that really gets the local one going. Yeah.
Cool. Okay, just over here.
Thanks. I just want to add something to the discussion, because I think probably the two of you might be aligned, but the point of view is different. And I think we should ask the question: is it a tooling issue, and what do we really want? So currently we are discussing on the base of the tool as it is, and not questioning if it actually is that we need something different from the tool, so to adjust the tool to our needs and not the needs to the tool that is available.
Yeah, it's interesting that you mentioned that. That also came up during our discussions, and we kind of avoiding that, opening that bracket. But it's really what is the goal and what is the consequence, right? And I think that is a very valid remark.
Yeah. Just here.
Yeah,
Thanks.
I will say related to archetypal templates, I think that's not that simple. Because going on into more specific clinical domains, we will find templates which are global into more specific domains. So I think there will be a situation where we have a global review on templates for specific domains. So maybe today it's like you said, Sylvain, but I think we will see that this will change.
Especially when you see at the European data health space. It will be templates that will be cross country.
Okay. Daniel's been very patient over here. Thank you.
Yeah, I'm a relative noob as well, but I appreciated your comment about it's not for developers. When I think about how we approach this in the kind of development community, no one says that something shouldn't be a public repo on GitHub because it's not globally applicable, right? GitHub manages to serve the dual purpose of very large projects that everyone collaborates and agrees upon, and very small niche projects. So I think I would agree that maybe it's the tooling that needs to change, because those local templates should surely be available somewhere globally, so that other people, they might not be right in their context, but it might be 90% right, and they should be exposed so that people can build on them, surely.
You can go to other people's CKM. It's in the end having GitLab and having GitHub.
Sorry, just
So this is a real beginner's question. openEHR is very new to me. So what's the trigger for somebody to set up a local CKM?
Yeah.
So I think it's really easy. It's you have a bunch of people using archetypes and templates in a country, and you feel the need that it has to be governed, or in a regional area, because otherwise things are going to get out of hand, so to say. So you need to do some governance, and I think that's what we use the CKM for.
Okay, we've got time for one more question, so I'm going to do a quick draw of the hands between Sebastian and you. Yeah, okay, Olivia. Yeah.
So just a quick comment about this idea of things trickling up, so to speak, from local CKMs or regional or national CKMs to the international one. That's extremely difficult for a lot of different reasons. It's much easier to do it the other way around, starting globally or internationally and moving stuff into a more local thing if you need to do that. So it's, I'm not sure whether that thing has the potential to be real in a large scale, to have things trickle out.
Well, I think there's going to be a lot more discussion around this, but it's certainly been a provocative question, and thank you very much. Thanks, Marieke. Thanks, Henrik. Cheers.